I expect within a couple of weeks that he will lose his hair.
A couple of weeks.
Okay. And everyone's a little bit different, and when he's off chemotherapy, if he's doing well, it will grow back. But that's kind of unfortunately one of the expected things. Those are kind of the big initial things that we tend to see. It's a class of medicines that sometimes down the road can cause other types of problems. So it causes changes to the DNA that is very good for the tumor cells, but can also cause problems down the road with the second type of cancer, unfortunately. And it's one of those things that we wish we didn't have to deal with, but unfortunately there's not a good way around it.
What other kinds of cancers?
The most common one is a type of leukemia. It's usually an AML type of leukemia, which is just one type of the blood cells. And that's, I think, just one of those problems that there's no way around it. There's not another good medicine.
But there's treatments for that if that happens.
There are.
Yeah.
But we're talking about, probably a 1% or so chance.
Okay.
So it's unusual. So.
Okay.
That's in that rare
Of getting it?
Of getting it.
Oh,
Of getting
okay.
the second cancer from the chemo.
Medicine.
Yeah.
Okay.
the group of the rare but important types of things to know.
Okay.
Questions on that type of medicine? There's another type of medicine that we've used. Like I said, it's kind of a big combination of all the different drugs that we have, called cyclophosphamide. That one, again, can make him feel kind of crummy. It's another one that he'll get lots of IV fluids to help protect his kidneys for. So when he's getting it, depending on the dose, he may need to stay a little bit longer to make sure that he's getting lots of fluids afterwards. Okay. That's another one that tends to make the white blood cells and the platelets and the hemoglobin be lower because it can make the bone marrow be pretty suppressed. So it's another one that we'd expect a couple of weeks after that he might need a little bit more transfusions, and we'd be watching for infections a little bit more closely. Those are kind of the big things that we commonly see. Sometimes it can also cause some irritation in the bladder because the waste products from the cyclophosphamide can irritate the lining of the bladder, which is part of why he'll get extra fluids when he's getting the medicine to kind of help flush it out and make sure it's not staying in the bladder too long. It also means that while he's getting it, we'll be checking his urine periodically to make sure there's no evidence of bleeding. And so it's kind of an annoying medicine to be getting because he's getting lots of fluids and having to go to the bathroom a lot, and we're checking those tests a lot. Okay. Those are kind of the big things that we commonly see with cyclophosphamide. There are not a lot of other big things. The next medicine, I sprinkled this in an unfortunate spot. So one of the kind of supportive medicines that we can use is a medicine to help boost up his immune system a little bit. So because we're not worried that this is a cancer of the immune system, we can have a benefit of using something called Neupogen, which is a immune boosting medicine, to help try and keep those periods where his immune system is low, short, and as short as we possibly can, so that he has a lower risk of infection. Okay. So when he's getting it, we'll kind of teach you and show you how that works. When he's getting that medicine, we'll check his blood counts periodically and see what the ANC is doing, the marker of his immune system. And then when it recovers, we stop it. When he's getting it, sometimes it can cause the bone marrow to be acting, very active, which is what we want, but it can be a little bit uncomfortable sometimes. So sometimes kids will complain that their bones are hurting and aching, and in little kids it's hard because they don't always know the best way to tell us that, so we just get kind of fussy, exactly, or we not want to kind of walking around quite the same way. So if that happens, then we want you to give us a call too, so we can kind of chat through what we need to do. Okay. And really that's kind of the big things that we think about that. The next type of a chemo medicine that we use is something called etoposide, which is something that again causes some damage to the DNA in the tumor cells. And again, it causes the same types of problems with the bone marrow being a little bit suppressed because it hits those fast dividing cells in the bone marrow too. It can make him feel a little bit nauseous too. And those are kind of the more expected things. The other things that can happen with that is that it can cause a little bit of difficulty with some elevated liver enzymes, so we can just watch those when he's getting his treatment. That's kind of the big stuff for that one.
It can cause an allergic reaction at times too, so when children get it,
what if it does affect his liver? What then?
Not much, honestly. We just kind of, if it was really bad, we could reduce the dose. But the liver regenerates really well, so we tolerate some injury. It sounds cavalier, but the truth is we accept it and we know that it'll grow back okay.
Yeah, I know. So. Absolutely, yeah.
Okay. And then there's another type of medicine that we use that's called actinomycin, which is like similar to that doxorubicin medicine that we talked about. It's a similar type of a class of medicine, and we use it for the same reason, that it works very well for the solid tumors. It's the same types of side effects that we look at with that. It's just a little bit like a cousin medicine of that type of medicine. So it's the same types of side effects and things that we would look for with that medicine. There's another chemomedicine that's called Temodar. That's a chemomedicine that helps it would be later on in his cycle of medicines, that helps attack the tumor in a little bit different way. And it's a lot of the same sorts of things. So it attacks fast dividing cells, and so it causes his bone marrow to be hit very hard, and his counts will be low again.
Do you need this room, Jerry?
Yeah. Yeah, of course.
Can I take over and I'll
Yep.
be happy to keep talking? Let me know if you need me for anything. Okay. So the Temodar, it basically chemically modifies the DNA. It's used at lower doses for longer term periods of time, and it's just a different way of approaching the cancers. It'll cause, the big side effects we see, it can cause some nausea, and it'll cause, again, the count suppression. Rarely it can cause some mental status changes and dizziness. It intensifies radiation, but if he's not getting the radiation, that's not that relevant to it. So, and then the last drug we have on here is actually something we're going to give him to help protect his heart from the effects of the doxorubicin. It's called Zinacard.
Okay.
It's pretty well tolerated. It's just we add it to the regimen because it's what we call a free radical scavenger, so it helps prevent the heart from getting quite as damaged. Occasionally, again, it can cause some injuries to the liver or the pancreas, but honestly, I think it's a very well tolerated medication. It can cause a little bit of pain when it's actually injected, but it's and it can have a little bit of effect on the white blood cells. But honestly, I think compared to all the other stuff that he's getting, this is kind of a modest effect. So I think that covers, it sounds like a lot, it covers everything. Some of these things on here are not, he is neither a woman of childbearing age nor a sexually active male, so.
I better not be.
What questions do you have about the drugs?
What effect do they have on his growth? I mean, he isn't walking yet,
So,
we're almost there, but
the vincristine could set that back a little bit. So the vincristine, as Dr. Simke was saying, works on what are called the microtubules, that are the scaffolding that helps cells divide. It's the scaffolding for your really long nerves too, and so the nerves that go to the muscles and for sensory and coordination and muscle control. We do see, especially with recurrent doses of vincristine like he's going to get, that you can get some numbness, tingling, but also weakness, and so it could set that back.
But when he's done, he'll be able
catch
to
up.
Catch up.
Okay. That's my question. Is it going to hold him back?
Well, I mean, it'll delay it, but it won't necessarily prevent it. Let's put it that way.
Yeah.
That's what I'm meaning.
He's young enough that it really shouldn't cause any fertility issues. The consequences of the consequences could have effects on growth. So again, if there was a severe infection, that can cause kidney injury, that can cause, other things that, we might need to manage down the road. But the medications by themselves, I expect that they'll maybe delay some of it, but, you should catch up. He's not getting radiation to the brain, so it shouldn't have as big an effect on cognition, which is one of the side effects of treatment with this protocol. Usually, when they have the radiation, the lumbar punctures built in. The secondary malignancy risk is the AML risk is there, but it's small. I think I wouldn't expect. I expect there probably will be some long-term effects where the delays kind of slow him down. The cisplatin, the hearing loss, is a potential late effect that's going to be significant because, and if it's getting really bad, we would adjust the dosing, which is why we'll follow him with audiograms before he gets doses. but that's significant from his learning and cognition because his language acquisition requires him to hear. So it's not uncommon that that's delayed or even leads to long-term, language and learning disabilities. And so we try and follow that closely. We have people who can work with him and provide additional resources. If he's having challenges, we help him get an individualized learning plan down the road. It's a lot of chemo. There's just no getting around that statement. It's a lot of chemo, and there will be side effects.
But we can address all
And
of that
we're
long-term stuff after.
Yeah, I think, my biggest worry about his long-term health is the tumor itself right now.
Right.
And so, all of those other things can be, I don't want to dismiss them as they're not nothing. They can lead to permanent handicaps, but we can help him work around those. Okay. And so that's, I think, a candid answer to a difficult situation. So, how about anything else? Is that the only question?
That's my mom.
Oh, do you want to ask
Is there
her
any
to?
questions, Mom?
Do you have any questions?
She might be on mute.
You have to take yourself off mute first.
I know.
Oh.
Do I have any questions? No, I'm overwhelmed by information.
Okay.
The only thing that I would ask them is this is actually like the start, a tumor in the heart. Even though it's rare, it didn't start somewhere else and come to his heart?
Believe it originated in the heart.
Okay.
You haven't found anywhere?
No,
except
there's no other sites of primaries that we've identified. It wouldn't have started in the lymph nodes.
Okay.
So.
Okay. Now, prognosis long term, survival rate through the chemo?
So this is what we were talking about before. Survival rate on the original protocols was about 20%. It's a bit better with the brain tumor protocol, so the data aren't completely mature. It's going to be better than that.
Okay.
I don't know what to say. I'm not sure how the fact that we can't do a resection or radiation, it might lower that a little bit. But that's so the numbers are a little bit individualized, but I think this is the option that gives him the best chance.
Okay.
Right. Okay, that was all I had because, like I said, I'm overwhelmed by information.
Yeah, I get that. Yeah, it is overwhelming, and so this isn't the last conversation that we need to have either. And so, as things come up, write them down. Even though I realize you won't all be coming down here, bring the questions. We can answer them. Sometimes if there are big changes in approaches or whatever, we'd convene another family meeting and we'd all get together again. Okay.
Right now it's prayer times.
Okay.
Alrighty.
Is there a calendar that starts
Yeah.
day one?
So
And do they get a copy of that?
We'll put that together. It's called a roadmap that lays everything out. We'll give you that. So I don't know if you brought one with you, or we can give it to you guys when you guys come in on Tuesday.
It's already been written out. It's the comment that you
pretty
use
standard.
for the other.
Yeah.
Gotcha.
So okay. Do you mind if I'm sitting next to him? We'll just go through this part. Okay. So these are the consent parts. So this is just basically acknowledging that we've informed you of everything that we're going to do. I feel like we've explained all of the side effects that, to the best of our knowledge, that you can expect.
Okay.
I guess what I'd add to that is the vague statement that you should expect something unexpected because it's a lot of chemotherapy,
I totally get that.
and we're going to work with them.
I understand.
Okay. We don't think that there's a better approach, which is why we're recommending this. I want to just acknowledge that you've had every chance that you need to ask questions, and I just want to reiterate that as more come up, this isn't the last discussion that we have to have.
Right.
And that you're agreeing to have us give him these drugs.
Okay.
We'd like both parents to sign, and then on this page here, with teenagers, a lot of times we like them to have some informed, we call it assent because legally they don't really get to consent, but we do want them to be active participants in their care. Obviously, he's just going, he's too young to have a role in here. So what I need you to do is also I'll sign it, you sign it, that we agree that you shouldn't have to agree to this.
Okay.
Okay? Does that make sense?
Yes.
Okay.
Do you guys know why the hospital would be calling?
It could be.
Maybe for
it might
Tuesday?
be Amy calling about Tuesday.
Okay.
That's why I kind of suspect.
Okay. Today is the 9th.
Yeah, 9.
April 30.
I don't think you really need to worry about the time on there.
So, what should we expect for Tuesday? Like, it goes by labs. I understand that when he gets to go home, make sure everything is okay. But I mean, what should I just expect on how many days we're staying the first go round?
So there's kind of one other piece of the story that we've been kind of looking at this afternoon about imaging. When kids are less than 1, sometimes they can have multiple different tumor sites. And so one of the other pieces of imaging that we don't have yet is pictures of his spine. And so Tuesday we're going to try and coordinate that to make sure that there's truly no
To get
there.
okay,
Yeah.
I see what you're saying.
So you'll come in, we'll have you come to the hospital. My suggestion, since this is the first time you guys are coming, we'll have you go to the clinic again, and our nurse practitioner, Taryn, will meet you. And I'm also on service. I'll try and see you at some point, either there or when you get back over to the floor. We'll walk you over and kind of talk you through just the whole being admitted part of things. Okay. So the clinic's up here. It's not a different spot from when you've been. The first admission will be several days. I believe it's about 5 days that you're here for the different medicines, and then you'll go home. The first day is going to be just the MRI.
It'll be an
we're
MRI.
going to coordinate that.
Okay.
And then when he's done with that, it will kind of determine the next phase of things.
Okay.
The only potential change is if we see something in the spinal area, then we'd have to talk about how we would treat that, and that's a little bit of a different kind of discussion. I don't think there's a strong likelihood, but just knowing his age is right around 1, I'd hate to not do it and then be, depriving him of some treatment that would help.
Right.
So that was kind of an ongoing discussion today that kind of just shook out. So that might be what Amy is calling about.
Okay.
So that'll be kind of the first part of things. When he's here, if he's getting chemotherapy and he's hanging out, then he'll be in the room, and then otherwise he can do all his normal stuff, being running around playing. Just make sure that there's no worries with the line being hooked up with the fluids and stuff.
Okay. So I can bring stuff from home. To make him feel comfortable. Toys.
Toys.
Okay.
Blankets. After changes of clothes. Stuff for you guys so you can stay the night.
Can't
And they're
bring the
private.
dog.
Yeah. They're private rooms.
Usually so. Yeah. Every so often, if things are extraordinarily full, we'll kind of look at having a friend in the room, but not that often. That's an exception.
They can stay the whole time.
Parents can, yes.
Yeah.
Okay.
Flu season tends to be a little bit more backed up.
Right.
Yeah.
Sure.
Well, the oncology floor is a little different in that we don't take all of those kids up here. We take our patients up here. So the patients with respiratory viruses and stuff are on the floors down below. So, it's more that still with the flu season, we still get a lot of our patients coming in with more of that too. But we just had an expansion. It's pretty uncommon. I think in most of your stays you're gonna have your own place.
Because there's a lot in the household.
Right.
So you put a lot in a household plus another family in a room.
Yeah.
They learned that on the hard floor. Now we're Smiths for a reason.
They'll run.
Exactly.
Yeah, no.
We have a lot of offspring.
Oh.
Yeah.
You guys have a busy house. They'll be good.
Okay.
Other questions about what to expect when you're here on Tuesday?
I think it'll come as a go.
And I know that this is a very big, overwhelming day in discussion. So, if you guys have questions through the weekend, I'm not on call this weekend, but if you urgently need something, just let the on-call person know.
Okay.
And if it's something that's immediately
Just write it down so you remember.
Right.
And then otherwise, we can always talk Monday too.
Okay.
If it's a less urgent thing.
How are you guys holding up?
We're doing okay.
Looks like you got a ton of support around you. That
We do.
helps.
We do.
Positive thoughts equals positive results.
That's the only way we can look at it, So I knew that Bone was coming back okay.
And I'm so glad that did. I think, like we talked before,
that's big news.
We kind of know what the odds are with these types of tumors, but we wouldn't recommend treating him if we thought that there was no hope that we would be successful.
So is there anything like we can donate, like blood or bone, nothing like that that's gonna help, or?
Vinny necessarily, but I mean, if you guys are looking to
In
do
general.
something, you can always donate blood, and it may not help him, but it would help another child.
Yeah.
I've said
He will get
It
blood
sounds
transfusions.
counterintuitive, but we actually don't want you to donate blood to him because there's a higher risk of transfusion reactions from related people.
I forgot about that.
So,
But he will be receiving blood.
Yeah,
Someone else's.
And it'll be someone else's.
Yeah.
But
you
a lot of my cancer families, they'll whenever they have a child get a bag of blood, they usually will like make a post like, all right guys, we just got a bag. Can you all go and donate today?
Yeah.
And then there's also bone marrow.
I know. I heard that
You could
today.
set up the swab. There's things we can do to help out other families.
Being on to be a match for,
Right.
to find out.
I've set those up before.
I would
Be the
willing
match.
to do that.
The last thing is I needed to ask for like other resources or information on the tumor.
Yeah.
So I have a couple articles that are things that are more kind of specific for this type of tumor.
General, yeah.
And so one is on kind of the background for the treatment protocol that's well established and what we're proposing to use for Vinny and planning to use for Vinny based off of our talk today. And then the other is just kind of like general about these types of tumors when they're not in the brain and not by the kidney.
Okay. Thank you for that.
Of course. What I'll say about them is that, just like in our talks, we're very honest and candid about what we think is going on. The papers are also that way. So they can be kind of hard to read, knowing what his situation is. But I think it's important that you guys have the information.
No, we prefer it to be that way.
Yeah.
Straightforward.
Exactly. Yeah.
Give it.
Shoot it to me straight.
okay.
I'm gonna have these guys for you.
Perfect. Thank you so much. John had asked for these.
Yeah, of course.
What's the do you have a ballpark figure on a number of what his like one out of how many hundreds of thousands of kids?
Get these?
Yeah.
Get the rhabdoid tumors of the heart or rhabdoid tumors in general?
Both. Do you have two different numbers?
I don't
Ballpark?
actually know it off the top of my
Right,
head
but like
for
a
that. I mean,
ballpark?
it probably says it right in there, like how common it is in terms of what percentage of millions of kids. I'd probably say it's probably around 1 in 10 million, honestly.
1 in 10 million for the heart.
No, that's even rare.
Totally different.
Yeah,
Bigger
again, I
number.
wouldn't
Okay.
perseverate on the heart thing too much, other than that it affects the resection
Right.
possibilities.
I really like that you said that.
Yeah,
actually.
I do
Put it in
too.
perspective for me, just on treatment wise,
Yeah.
period. That makes sense. Yeah.
Absolutely.
But I mean, it is affected, or it affects it on terms of you can't go in there and just keep taking it out. But looking at it just from a prognosis and moving forward state, that was really awesome when you said that. Thank you.
Welcome.
Any other questions or things that you guys want to talk about today while we're all here?
Okay, thank you.
There'll be questions wrote down next time.
Yeah.
Because I had so many coming in.
Right, and
I
you
just
had-
feel like I got most of my questions were answered, and I didn't even have to ask questions. So.
Right.
Good. So when you come in on Tuesday, Katie will still be on service. My colleague, Dr. Schupeltz, will be rounding on service, so you get to meet her too. She's actually another one of the attendings on the Monday team, so you get to know her. And then I think Dr. Hash, she's been also, he'll ultimately be the one quarterbacking this over the long term. So
It had you on here, which I was used to. Taryn Gales.
she's our
Sandra
nurse
Heinrich?
practitioner.
Oh, nurse practitioner. Okay.
So you'll see her first thing in the morning, and
Okay.
just kind of, and she'll help get you.
Because she had been on most of our
Checked in.
stuff, and then I saw that one, and I was like, but I didn't pay attention
Yeah.
to NP nurse practitioner.
It's a pretty big team. You'll see lots of people through your time in the hospital. More doctors than you want to get to.
Yeah, John was like, I'm not gonna know. He's like, I'll know my face. That's about it.
That's totally fine.
Yeah.
And get the big group come in of 15.
Oh, awesome. Thank you.